Hi, everyone, and thank you for joining me. I am really excited to talk to my friend and colleague, Mimi Ellis. So Mimi is a registered licensed dietitian nutritionist. How do you say that?
Registered dietitian nutritionist.
That's it. Registered dietitian nutritionist. She's also a physician assistant with expertise in ENT. I'm not even going to say the word, or the ENT, dealing with the ears, the nose, the throat, which puts her, straddling that the disciplines between nutrition and sleep medicine. And I'm just telling you all the things that she does that I find interesting. And she also has a lot of experience with the issue of loss of smell that a lot of people have had due to long COVID and post-COVID. So every time I have a conversation with Mimi, I want to have another one. And I thought the things I want to talk about this time, I definitely want my clients to be able to be a fly on the wall so they can hear this conversation, which is why I wanted to record this. So thank you for joining me, Mimi.
Thanks for having me. This is great. It's always fun to chat with you.
Yeah, I agree. So can you could you update me a little bit on your background, on your journey from being a dietitian and how you got involved in these other aspects of health and medicine?
So, started out as a dietitian in '93 is when I initially got credentialed as a registered dietitian. We didn't have the nutritionist distinction part yet. Oh, good. You got your coffee or tea too. So nice kitchen table conversation. This is great. So I did that, and I knew pretty quickly in the early '90s that I would be bored within a few years. Mm-hmm. And I was fascinated. I was fascinated with, the sicker, catering to sicker patients, as opposed to, back then it seemed like all anybody wanted to do was, wellness and weight loss. And, I wanted to go work with the oncology patients, that were struggling to, to get through radiation and all that stuff. So I did that and started taking my pre-med prerequisites, thinking I was going to go to medical school. And then many of my physician friends at the time, I was working in the hospital, said, if I had it to do over again, I'd go to PA school because you get to have a life and do medicine. And I thought, I have lots of hobbies and interests, and maybe that makes more sense for me. So that's what I did. I went off to PA school in Glendale, Arizona in 1998 and graduated in 2000. And then by 2003 was in a very busy office-based practice with a solo OBGYN. So it was just he and I. And, it was great, but it was fairly high stress. And that was right around the time in the early 2000s that what was the American Dietetic Association came up with a very paperwork intensive way to keep up with our continuing professional education. Mm-hmm. And I already have 52 hours of continuing, or 50 rather, hours of continuing medical education I have to do for my PA license. So I resigned my credential thinking I'll never want to do this again. Practiced as a PA for now 23 years and had a couple pretty serious injuries in 2000 and 2001, where I had to step back from office-based practice and decided, I could be a dietitian and do that pretty much from anywhere. And it's not going to depend on my, physical state. Mm-hmm. So I went back and I took my RD exam again, 28 years after I did it the first time, and became a dietitian again last year. And that's kind of how I got here.
Gotcha. And can you also tell me about your journey? Because you work with smell loss. Pronounce that word, anosmia?
Anosmia.
Anosmia?
Yep. So anosmia means no smell. I actually got interested in that because a few years before the pandemic, it was actually in 2017, I lost my own sense of smell. And it was about this time that year, and I had been working in ENT and had seen, a handful of patients over a few years with smell loss, so I knew a little bit about it. As you know, I'm a total foodie. My family is French. We grew up in the kitchen and having everything in life be about, what was the next meal we were going to make. So when I lost my sense of smell, it was a really big deal to me personally, because I understood the implications of that. So that's how I got interested. And back then there was not a lot of research. And what prompted me to look for answers was I have a daughter who is 3'11". She has the most common form of dwarfism. And she was training with a Paralympic swim coach with a whole bunch of swimmers with various physical challenges, many of whom have actually become Paralympians. And I literally met kids who, their parents told me, yeah, we had this accident when he was 5 and we were told they would never walk or talk again. Or I literally met a child, she was a teen at the time, and she was born with a condition where literally half of her brain didn't develop. And her parents, were told she'll never be able to walk or talk. She'll never be able to feed herself, and here's this kid swimming on a pre-Paralympic swim team and getting ready to go off to college. And I thought, if that's possible, there has to be a way that we can retrain our sense of smell. So I just kept digging and, going farther and farther down on the Google search because it didn't come up, in my initial search. And I found a woman named Chrissy Kelly, who is based in England. And she had been working with a physician named Thomas Hummel, who's a fairly famous scientist in Dresden, Germany. And he had published a few studies showing that olfactory retraining actually does work. And she was actually starting to teach some smell retraining workshops. So I found her pretty quickly and got into her workshops and started smell training and just started learning everything I could, and never thinking there would be, 30 million people around the planet now suffering with various aspects of smell loss and distortion and all of that. So
because you put together a program for people, didn't you?
Well, I put together, I thought I might be able to help people as a health coach. So I did get a health coach certification. And what I found was, I think there just is not a perception. There's not enough people that understand there's things that you can do to accelerate your recovery. And that there's things nutritionally we can do to support the recovery. And there's not a ton of research yet. There's some on a couple supplements. But obviously, being a nutritionist, I knew how quickly my own health started to deteriorate because I just didn't feel like eating. And I was so upset when I had the diagnosis. And I just kind of felt like I was swimming upstream because unlike, pre-diabetes, right? People know if I don't do something different, the future doesn't look great, right? But people with smell loss, I'm finding very often, want to just wait till it gets back to normal, or they have an idea that if it doesn't get back to exactly the way it was before, then I'm not interested. Not really sure. So at any rate, I do have a course to teach dietitians how to help people with smell loss, because I feel like that's important. If we're working with somebody that's dealing with that and we don't know how to make food interesting and make it, make it where they want to eat it, but also give nutritionally what will support recovery. I did do that. And then right now I'm kind of going back to a more general practice, a little bit like what you're doing.
Right. Yeah, because you're the only person I've talked to who deals in smell loss.
That's funny. I mean, there's other, there's other people out there. I'm sure there's other dietitians. I've run across at least one in my travels online. So I don't know, maybe that's something, maybe there's still more to do with that. There are actually a couple of nonprofits, one of which is founded by Chrissy Kelly. So there's a lot of free resources online, which are fantastic. And that's where I've learned a lot of what I know.
Right.
So I don't know, it may be that people are getting their needs met that way.
Yeah. And in your experience, I know your experience was different, but people who lose their sense of smell in COVID, do you get the sense that some of those people, this is a long-term situation?
You know, it runs the gamut. And, you know, the biggest thing to know about this is the recovery is not linear. You know, you get a little better and then, you know, for whatever reason, you know, and I'm kind of up and down. It's never super predictable. There are a few things that are specific to COVID that we weren't seeing with other viruses. And mine was viral, obviously not COVID. But with COVID, it does seem to last longer. Even in the ENT office, in the absence of smell loss, we're seeing inflammation in the sinonasal areas that last months and months and months, you know, beyond an initial viral infection, which is not what you would typically see with other viruses. So there's something different. And then, yeah, it does seem to last longer. And then there's about 50% of people that have pretty severe distortions as they're recovering, and that's called parosmia. And for those people, it, you know, it can just be debilitating, where they can't be in the house when food is cooking, or they literally want to gag or throw up. And yeah, it's pretty serious.
And a couple of minutes ago, you said something I thought about. You said there are some supplements and things. So, and then you mentioned the high inflammation. Are people using supplements or strategies that decrease inflammation? What are the strategies?
Yeah. So, you know, and I have been saying this in the, you know, in the community, particularly the one that I'm most active with is called Absent, and that was founded by Chrissy Kelly, about anti-inflammatory diet, you know, and does that help? And there seems to be some research now emerging that may help with long COVID in general. But there have been a couple of studies done on fish oil supplementation, which does seem to help. And then there was an Italian study that was done on, see if I can say it right. It's called palmitoyl ethanolamide. It's abbreviated PEA, but you have to be careful because there's something else that's PEA that's totally different. And you have to be careful in your Google search if you're going to read about it. But it's palmitoyl ethanolamide with luteolin. And they did a study in Italy, double-blinded, placebo-controlled. And they found that people taking that supplement that were doing smell training as well, compared to those that took the placebo, actually recovered. They had a greater recovery and they had a faster recovery.
Okay.
Yeah. So those two things can be helpful for sure. Yeah.
Right.
A lot more research happening. You know, that's one of the silver linings that's come out of the pandemic is there's a lot more people now. So there's more
money for research.
Subjects. And there's more money from research because there's more people.
Yeah.
Yeah.
So, okay.
Yeah.
I'd love, if you don't mind, I'd love to pick your brain a little bit about sleep medicine.
Yeah.
CPAP machines, using those, alternatives to those, and talk about your experience in that.
Okay.
In particular, so, you know, because both of us work a lot in metabolic health. And in metabolic health, especially pre-diabetes, blood sugar, we see a lot of people who have obstructive sleep apnea, or in some way their sleep is problematic. That is raising cortisol levels, increasing insulin resistance. So that's a root cause that we're always looking at.
Right.
And so I'm going to ask just some specific questions. I want to take advantage of this. So one, I'll get clients often where, you know, both you and I use continuous glucose monitors in our practice. Right. And when I'm looking at their overnight data and we've troubleshot, and we've eliminated other things, I'm thinking there's something going on with your sleep. I know that they snore, but their glucose levels, I think you need a sleep study done. And a lot of people will not get a sleep.
Staying up at night. Is that what you're, yeah.
They just have this, their baseline is just ratcheted up about 30 mg per deciliter-ish. And their excursions, their glucose excursions from baseline look good. Their diet, that's not doing anything, but it's just staying high. And so when I recommend, like, I'd like you to get a sleep study done.
Mhm.
And a lot of people won't do it because I think they don't know. They think they have to go into a lab to do a sleep study, which is hard. And they're scared about getting a CPAP. They think that they
Right.
just don't want to get it. So
Yeah.
I have a lot of questions. One is, can you tell me, do you know what a sleep study involves and what the options are?
Yeah. So those are great questions. And, you're observing the same, the same things I observe with my own, clients as well. So now, because doing a home sleep study is much less expensive, and for, I don't know, probably 95% of the people we test, it gives us the information we need to take a direction and, get them plugged into the right treatment. Insurance almost always requires a home sleep study before doing anything in the lab.
Okay.
And they generally do cover a home sleep study. Now, you got to look at the whole deductible thing and all that. So the financial concern may be there. On the other hand, I've met professionals that don't want to do a sleep study, but they go out and buy a $300 sleep tracker and tell themselves, that it's the same thing. I'm like, no, that, it doesn't work that way.
So an Oura Ring is not a substitute for a sleep study, is what you're saying.
Correct. Now, I mean, it can be a good way to reinforce how somebody's doing with sleep. But as far as an actual substitute for a study, it's not going to give you all the data points that you'll get. And it's not interpreted by a board certified sleep medicine specialist who would read the results. So with the home study, basically you wear a very non-invasive device that goes on the head. Sometimes there's, a different nose piece and a heart rate monitor and a couple, different things, but it's not like when you go to the lab, you have electrodes everywhere. You've got things beeping all night while you're trying to sleep. It's difficult in the lab. Not that there's not a role for it, but at home, it's easy. It's non-invasive. Generally, at least how we have it with our office, people will come in the day that they're going to do the study that night. They pick up the equipment. They have, a 10-minute office visit with one of our medical assistants. They learn how to use the device. They go home, they do it, they bring it home. They bring it back the next day. And then all the data is uploaded and downloaded wirelessly. And then my supervising doctor, who is also board certified in sleep medicine, reads the studies, makes recommendations, and then we see them back and we talk about what the options are.
That seems like a very non-issue.
Right?
That seems easier than I thought it would be.
Yeah, it's not hard. It's not hard at all. And really that answers the big questions. The way I explain it to people is, we want to know if you're just making noise when you snore, which may be a problem for your bed partner, or somebody else, or are you actually dropping your oxygen and are you losing out on deep sleep?
Right.
And then we can decide where to go from there. Sometimes we'll pick up heart arrhythmias. Sometimes there's other things that we'll pick up on a home sleep study that then, medical things that have to get evaluated, but pretty benign process.
Kind of seems like considering that sleep issues can be a root cause for a lot of the things that lead to early heart disease and whatnot.
Yeah.
I'm starting to wonder if a home sleep study should be a little more routine than it is.
You would think, right? You would think. And, and I think some of it is, we live in a culture that does not, we don't value good sleep as a culture.
Right.
So we value workaholism and, working ourselves into the ground.
Right. Whereas once I started tracking my sleep, I've used an Oura Ring for about 6 years.
Yeah.
Because I have a history of poor sleep. And now I feel like I'm training for the sleep Olympics. I wake up in the morning and report to my husband. I'm like, I got a 93. Oh, I'm down to a 92 today. And so it's actually, I've kind of transferred my ambitions to better sleep.
Well, and wise, and you're wise for doing so. And a lot of times what I have to explain to people that don't want to get their sleep study is I just say, look, there's 5 things we need to live. We need water, we need oxygen, we need food, we need clothing on our bodies, and we need deep sleep.
We need deep sleep. And you don't get deep sleep when you have
And-
obstructive sleep apnea, do you?
Or lots of other, sleep disordered conditions.
So let's say someone does a home sleep study and they find out they have obstructive sleep apnea. What are their options? What's the gamut of things that they might have as a solution?
Yeah, good question. So it depends on the severity of the apnea. So assuming it's obstructive sleep apnea, which is, almost always what we're going to see. For mild sleep apnea, your least invasive options are going to be typically either an oral appliance, which is kind of like a bite guard that athletes might wear.
Oh, that's
except
nothing.
Well, it's not bad. It's custom fitted. And then every couple of weeks, you go back into the person that fitted you for it and they adjust it a little bit. And what it does, it's called a mandibular advancement splint. And what is it does is it pulls the mandible forward so that it's pulling the airway, pulling the tongue, the base of the tongue off your airway when you go into deep sleep. And they basically titrate it. You just adjust it a little bit each time until the patient comes back and says, my wife says I'm not snoring anymore, and I finally started dreaming again. And then you go, okay, we're good. And then you leave it alone and see how they do. And sometimes you have to tweak it some more. Sometimes, you're done. It's not great for somebody, that's maybe had a broken jaw or that has clenches their teeth a lot and has a lot of TMJ pain, because it can aggravate that. But a lot of people do great with it.
Is this what people call a dental appliance?
Possibly, or an oral appliance is how we usually refer to it in the office. Yeah, so what else was I going to say about that? Then there's other things that ear, nose, and throat docs can do, and we do some of these in our office. And these are like minimally invasive surgeries / procedures, things that would make a little more room in the airway. So it might be, I don't know if you remember what turbinates are. They're the sort of sausage-like structures on the sides of our nose, and there's 3. There's inferior, middle, and superior. And they can do a procedure where they go in under the mucosa and with a specific type of, usually it's radio frequency, I want to say, they'll shrink the turbinates a little bit so that can give you some more room in the nasal airway. If somebody's septum, that's the middle wall of the nose that goes up and down. If it's really deviated and they just have, maybe one side of their nose, they just can't breathe at all. Sometimes repairing that will help. Sometimes they can use also radio frequency ablation to shrink the base of the tongue a bit. And then also, if somebody's got huge whopping tonsils and they think that's a factor, then sometimes getting the tonsils out. In kids, that's almost always the treatment for obstructive sleep apnea. Other than older, overweight kids without big tonsils, it's almost always going to be get the tonsils out. And
that, I don't know about you, but when I hear some of those things, it sounds like inflammation can play a role in those. If you've got inflamed lymph nodes and things. Is that ever an intervention that people do where they're like, well, we back up and see if there's some food intolerance or is that an intervention that is used?
I have only recently, and I'm trying to think of where it was that I heard about this. Somebody was talking about a case study where they did that. The challenging thing in kids is when they're school age, that's when their lymphoid tissue becomes very active because they're training their immune system, right? And they get 6 to 10 colds a year. So if they inherently have big tonsils and then, that the tonsils are staying so big that, they're literally occupying almost all of the airway, I'm not sure how much you could get the tonsils to shrink.
Gotcha.
Doing anti-inflammatory diet and things like that. Allergy often plays a role. again, I don't know how much data there is from a functional medicine standpoint.
Yeah.
On that. But what I can tell you with kids is, if they're walking around with sleep apnea, and think about what we're asking them to do in school every day.
Oh my gosh, grow, not to mention just grow.
Right, just grow. That, it's
oh my gosh, yeah.
Yeah. And it's, it's a recovery that's much easier as a child than as an adult.
Yeah. That seems like it would be a game changer for a kid.
It often is. And I mean, my favorite story is a 13-year-old boy who came in with his parents, and he didn't want to tell me, but I always ask, because it's, it's one of the things I can put to increase the odds that insurance is going to cover what they need. And I asked him, do you still wet the bed sometimes? And he just started crying in the office. He was 13 years old. He's like, yeah. And I don't go to slumber parties because I'm embarrassed. Got his tonsils out. He stopped snoring and stopped wetting the bed and started feeling like $1 million.
Talk about changing someone's life.
Right.
So can I shift over to CPAP machines?
Of course. Oh yeah, that's important.
Because I have a lot of patients using a CPAP, or they're supposed to use a CPAP and they're not using a CPAP.
Right.
And more recently, and I kind of want to tell you some background so you can give me some insight on this. I have one patient in particular who I'm thinking of, and she's very savvy. The company, I think I wrote to you about this too, the company she gets her CPAP supplies from isn't being very responsive, isn't sending the replacements. So one, I'm curious, how do I order all my questions that I have about this? One, she knows this, but she told me friends of hers don't, that when you have a CPAP machine, it's not a one and done thing. Like you need to clean things, you need to replace parts on a regular basis.
Yep.
So can you tell me the process of like getting it and maintaining a CPAP machine?
Yeah. So, the first part, and in my office-based practice where I do my PA work, we try to really, really educate people about this, because I think so often they don't get educated and then they're frustrated, why doesn't it work the first time? And that's that there's going to be a good bit of trial and error at the beginning, even just to figure out what kind of mask works for you. And then even within that mask, there's going to be certain things about the, adjusting the straps and the position of it. And then there's the settings on the machine. So from the get-go, I think people really need to understand that there's some trial and error, and they have to be willing to work with the sleep medicine company to basically to get through and figure out what works for them longer term. And that can be tough. And we're having a lot of similar issues. And I think it's just because they can't hold on to staff long enough. So the people that are there just can't keep up with the demand. Plus there was just a huge recall, a year or so ago. So people are still trying to catch up on that. So once we get everything, we get the settings right, we get it working, patients will come in and they'll go, oh my God, I feel like $1 million. I had no idea how tired I was. I go, yeah, because you didn't just wake up tired one day. This happened over a period of years. So you didn't know, but they have to do compliance checks typically every 6 months, which all the data is uploaded and downloaded wirelessly. We get a report that shows how many hours each night they've been using it, what settings it's been operating at, how many apnea episodes they had, if there's leakage, which you want to know, because if the mask is leaking, then it's not going to actually keep their airway open. Yeah.
Okay.
And then, they have to do the changing of tubing, and there's some part of the supplies that have to be changed out. And then there's typically, and we always recommend that they get the kind with humidification, so that they're not getting dry air all night long. And then of course that has to get cleaned. So there's some maintenance involved for sure.
Right. But, so is what you're saying that when people decide, okay, I need to use a CPAP machine, the first part is, getting the equipment. and then going into their office, their sleep medicine office, and having it fitted for them and adjusted.
Yep.
And then, and they might need to just bring themselves back in and say, this isn't working. And it might be a tweak. It might be order a new part.
Yep, exactly.
So it sounds like those people who are successful with a CPAP machine are people who are like, give themselves over and say, I'm going to spend some months getting this dialed in and being willing to be the squeaky wheel, not necessarily squeaky wheel, but saying, just understanding that this is part of the process.
Right. And you have to be proactive, and I think, gosh, we're so used to, a culture that provides everything we want, rapidly, right?
Mm-hmm.
That I think sometimes we've lost the skill of waiting and persevering a little bit and trying different things. And I had a patient who's an engineer, and he ended up engineering his own mask because he just didn't like any of the options. And like, whatever works, I'm happy. Compliance report says it's working.
Right. So if you don't like, if your CPAP machine isn't working, you don't like it, don't just sit there and put it in the corner. Basically don't give up on yourself. Go in, ask for help, order a new thing, because that's how it works.
Exactly.
You're not being that client. You're being proactive, and that's what it takes.
Right. And they know, and I'm sure, they factor that into the cost, that there's going to be masks that get returned, and that's just kind of how it is. And the companies work differently. Some of them will send a tech out to their home. Some of them have a central office where you have to come in and they have all the stuff there. So exactly how it works is different, just depending on insurance contracts and all that kind of stuff.
Yeah. So another question I have, because I often like to do, I'm a big fan of the $5 fix of, or if people don't want to go into sleep medicine, I'll say, well, why don't you try this? Because, I'll work with a lot of DIYers who don't want to go in or spend the money. And so sometimes I'll say, okay, if you're not going to do that, I'll recommend a free app on their phone called SnorLab.
Oh, cool.
Have you heard of SnorLab?
I have not.
So SnorLab is I'm looking at this. It's an app that it basically records you sleeping.
Okay.
But when you get the report, you can just listen to yourself sleeping all night, but it gives you a visual representation. So you can see just visually the high peaks are when you're noisy. Yeah. Yep. And so you can go to that area and hear what it sounds like. So you can hear if there's some obstruction. And because I remember my doctor telling me a few years ago, she said, Karen, over half of post-menopausal women, regardless of their weight, have sleep apnea. Mm-hmm. And I thought, and I was I'm a post-menopausal woman. No, I'm a fairly slender person, and I snore like a steam train. I snore. And I have developed mild sleep apnea. And I figured this out by using SnorLab. And I actually listen to myself snore, which I don't recommend. It's a horrible sound to hear your own snoring.
Yeah.
And then
did you pick any of that up on the Oura Ring, out of curiosity?
Was this before I started using Oura Ring? I didn't pick snoring up on Oura Ring, but I noticed, I'll tell you what I picked up on the Oura Ring. What I did next was, one, I started sleeping on my side more. And I started using the mouth taping because my apnea wasn't, and I would tape my mouth closed, sleep on my side. And I keep my nose clear. Like I'll use a neti pot to so I can breathe through my nose. And I noticed that I was getting a substantially more deep sleep that way. And I wasn't, snoring myself awake. You know how when you sort of, you wake up.
Yeah.
And if I don't tape my mouth closed, I snore myself awake and then I don't get much deep sleep. But if I tape my mouth, I sleep on my side, that's the level I'm at. So when you hear that, I'm curious about, do you have red flags going, oh, do not recommend that to people, Karen? Or tell me what you think about that.
No, I mean, I don't have red flags. There's actually, and I think you and I talked about this before, and I think we both read James Nestor's book, which talks about how the shape of the human skull has evolved over time. largely because of what we eat, but that it's affected the shape of our airway. Also, our brains have gotten bigger, so the skull had to make room for the bigger brain, and it took room from our sinonasal passages, right? But that's one of the things he talks about is mouth taping. Leave yourself a little airspace just so, if God forbid your nose was obstructed, you're, not going to die or something. But, there is some data to support that if you do that and you sort of force yourself back to becoming a nose breather, that your nasal passages will function better.
Right.
So I don't think there's any harm in that. And I think you can even get like specific devices that will keep your lips essentially closed, but with a tiny little air pocket somewhere.
Okay.
And sleeping on the side, definitely, if it's the back of the tongue and the palate that's obstructing, and you sleep on the side so that it's not falling backward into the airway, and you can sleep on your side. I just got over frozen shoulder in both shoulders. So, sleeping on my side still makes me want to cringe.
Right.
But if somebody can sleep on their side, that's certainly an okay place to start. And yeah, something that's going to show you if you're snoring.
Yeah.
And then you can listen to the snoring. And, little kids always think this is really funny when I do it in the office. But there's a characteristic sound of sleep apnea, and it's something like,
yep,
that kind of sound. So, if you're hearing that, for sure, you probably ought to go get a sleep study.
All right. So using the SnorLab as a stepping stone to maybe convince somebody that they do need a sleep study might be something.
And I think just reframing it and going, how do we know that you're getting deep sleep? And deep sleep is one of the things without which we eventually die.
Yeah.
We die slowly, right? But
Certainly.
it takes 1 or 2 days to get insulin resistant and for our glucose metabolism to get out of hand. And I would much rather get my sleep evaluated than have to go on some crazy diet to try to get, my blood sugar down.
Right. So let's talk about that, because that's something I'm running into is when I run groups on continuous glucose monitors. Like, I know that you're doing that too.
Yeah.
I'll see people who like I said, their baseline is up higher than you'd think it would be given what they're eating and their exercise. And they are banging their heads against the wall and stressing themselves out, trying to get their baseline down by restricting their diet more and more and more, and doing fasting more and more and more. And then I go, what? I think you're doing what you need to do with your diet. I think it's your sleep. So it's exactly what you're saying.
Yeah.
So what are you using in your work using continuous glucose monitors and working on people's metabolic health?
Same. And I had, what really blew me away was starting to work with one particular client who had already, I want to say a week or two before she put her monitor on, she had actually started using and I forgot to talk about this. We now, people, lay people will still talk about this as CPAP, but now the standard is auto PAP. So PAP meaning positive airway pressure instead of continuous, which is the C. Most of the time now we use a device that is going to automatically adjust how much positive airway pressure it is sending in, depending on how much resistance is in the airway at that moment, which is going to change with sleep stage and with position. So they're a lot better tolerated. Okay. How did I get on that? Oh, so she had started using her auto PAP. And I don't think I knew that she had started using it yet. So a few weeks went by from the time that I first heard about her, and then she got into my program and we started monitoring, and I had her labs from
You're monitoring, when you say monitoring your glucose,
her glucose.
using CGM?
Yeah. So I had her initial set of lab work that was a few weeks old, and I looked at her lab work and was like, yeah, she's pre-diabetic. This is going to look horrible. And I started looking at it, and it didn't look horrible. and I was convinced that the device was defective. And I spent an hour on the phone with the folks at Abbott trying to convince them that their device was defective, only to find out at the end of the conversation, my client says, "Oh, well, I just started using my AutoPAP a couple weeks ago. Do you think that brought my blood sugar down?"
Maybe.
Yeah. 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 Based on what your lab work, 3 weeks ago said,
Yeah.
that was probably it. And, she's had a pretty easy time keeping her blood sugar in control since she started using her AutoPAP.
Yeah.
One day she told me, she's like, I just dreamt for the first time in decades. And one night we had a call, it was in the evening, and she said, I just have to tell you that before I started using my AutoPAP, I would be asleep on the couch by this time. And I'm up talking to you feeling really good. And I feel like I have another couple hours in me before, the day is over. It's pretty amazing.
Yeah, that is amazing. And I think the most amazing thing about that is that people can progress in that pre-diabetes, diabetes, and feel so like they're not empowered with how to fix it. They might go on a medication. I'm not anti-medication. If medication works, it's great.
Right. Or if you need it, you need it.
But they never they don't get evaluated for that sleep study. And being able to do your program and look at glucose levels and see what helps and what doesn't, and seeing that her food is not a big issue. You just saved her money, time, her life, basically, by identifying that.
Yeah. Yeah. Well, she came into our office, so, we were right on the sleep thing. And she actually knew, because I think 20 years prior, she had a sleep study, but like you were talking about, she was one of those people that tried the first thing out of the box, didn't like it, threw it in the closet, and waited 20 years before coming back and saying, maybe it's time.
Yeah.
Yeah.
So tell me a little bit about you've been doing some programs with continuous glucose monitors, haven't you?
Yeah. One program. I have a few people that are just in my program, which is a group coaching situation. And then I monitor the glucoses remotely. And then we get on coaching calls, and then, they talk to me in between if they have questions, or if I see something on there, then I'll reach out to them. And then a couple of our private clients through the office that have come in that do one-on-one work with me are doing it that way. So it's definitely been effective. I had not just in terms of sleep and energy. I know when I first heard you talk about this, I think what really piqued my interest was you talking about people with chronic pain feeling that much better, sometimes as soon as a couple weeks. And I have somebody that finished my program that is a chronic pain sufferer, and she felt, her pain diminished a lot by going through the program. Somebody else dropped his blood pressure, his systolic blood pressure. He dropped 20 points in just 2 weeks.
In 2 weeks.
In 2 weeks. No medicine.
Yeah.
Yeah. Pretty.
That is fast.
It is fast.
And what do you think it is that's helping? Why do you think that's happening so quickly with your patients?
Because I think people have the immediate feedback. They can look at exactly what they just did an hour ago and go, my body didn't seem to like that too much. What do I need to do to flatten the curve next time? And, it's often as simple as adding something in as opposed to taking something out. Or maybe.
Don't you love that advice?
I love that. And just changing up the proportion of things, or changing the timing of things. Whereas,
because everyone thinks that going to a dietitian, they're going to take out all my favorite foods.
Right. Yeah. No, cool. I don't like to take things away.
No.
We put things in, and by default, the things that we want less of will show up less. That's just how it works.
So who do you like working with the most? Like, who who are the clients you really feel like these are the people I can help in your private practice?
I honestly, I think the ones I can help the most are the ones who are ready to also look at the impact of their relationship with food on their health choices.
And does this mean like eating disorders, or does this mean like comfort eating? What does this mean usually?
I would say people that are ready to look at, and I would say more disordered eating than eating disorders, if that makes sense. Not necessarily DSM-5 criteria eating disorders, but, people that eat to take the edge off.
So everyone.
To a certain degree, yeah.
Yeah.
But, if I hear one more person, tell me I fell off the wagon today, I'm like, there's no wagon. There is no wagon. What are you talking about? Like, we're just looking at what is it that you want to do today? How do you want to feel today? How can what you eat and how you eat and why you eat support that? And you know what? There will be days that there's a gap between what you said you wanted to do and what you actually did. And okay, we move on. We don't necessarily go, I'm off the wagon. I may as well go eat, 3 large pizzas now.
Right. And that's where your coaching experience comes in, I expect.
I think so. And probably just my own experience, having been a chronic dieter, and weight cycler till I was 23 years old, and eventually became an intuitive eater. So much so that I sometimes don't know how to teach people how to do that. So I've actually started the process of enrolling in a course to become a certified intuitive eating counselor. Because what's obvious to me after all these, sorry, what's that?
Add yet another certification to your list.
Well, I think that comes, that's a product of being, or I should say, that's the result of being the product of a couple of narcissists. Got to have lots of letters after your name, to feel like what you have to say is valid.
Exactly. Well, I think
which I can laugh about now.
Yes. Yeah. Well, we do that as we get to a certain point in our lives.
Yes.
But I just think so much of what you have to say is valid. There are still more questions that I would love to ask you. I want to talk about culinary nutrition work that you do, our next conversation should be culinary nutrition, more about intuitive eating, I'd love to hear more about how you work with, people's relationship with their food, because it's one thing to be able to identify all these things, but then it's another one to support them on a day-to-day basis to help them make those choices.
Yeah.
So,
and how to blend it with, and this is what I'm really looking to get out of this next series of training, is how to blend that with, the fact that many of us reach middle age and our health changes, and we may have to make some changes in how and what we eat to support our health. And how do we do that in a way that doesn't send us right back into diet culture?
Yeah.
And diet thinking.
Yeah. For sure.
Yeah.
I think that's a great place for us to kind of put a bow on this conversation, because that is going to open up a whole bunch of stuff I want to talk about next time.
Cool.
For the next time we have a chance, because I know this took us a few times to find a time that worked for both of us to talk. And so I'd love to do this again. And for those of you listening, I've put Mimi's website here on the banner. When I share this, I'll also put her website, and Mimi has this great free guide that you can download on getting great sleep. So if you don't want to just type this in, I'll put that in the notes here for people watching the replay. And is there anything else people should know about how they contact you?
You can message me on the website. You can actually request a free get to know you chat through my website. And Let's see, that's probably the best place. Also, our practice, if you happen to be local and in Georgia, find us at Julie's Zweig, ZWEIG, MD.com. and we'll be glad to take a look at you and help you with your sleep.
Okay. Make sure I put all those in the notes on the replay.
Cool.
Thank you, Mimi. Thank you for answering
This
all my questions. I feel like I should get continuing ed credits for this conversation.
Yeah, let's do that.
All right.
Thank you for having me. It's always fun to chat.
It is. It is. Take care. Thanks a
You
lot.
too. All right.